We want to take off and welcome everybody to today's Kenya Society of Anaesthesiologists hosted webinar. Our faithful audience and all of you who are tuning in for the first time, we thank you for joining us. We at the KSA are honored to host you, our ever-expanding family, drawing from not just the anesthesia fraternity, but various other allied specialties and cadres, both here and beyond our borders. We are extremely privileged to host you. Our invited speaker, Dr. Maxine Okello, thank you for gracing us with your time and effort with today's presentation. The Executive Committee of the KSA for organizing this series. The KSA and all her members and partners, not the least of whom includes our sister society, Critical Care Society of Kenya. Michelle Mithmacharia, our society administrator, thank you. I am Angela Ongewe, and I will be your moderator this evening. I ask that we please keep our microphones muted and our videos off for the duration of the webinar, unless invited to do otherwise. And I welcome you to drop your questions and comments in the chat box, and we'll address them during the Q&A session. So for now, let's jump right into it and welcome Dr. Maxine Okello. She's a perioperative clinical fellow in the Anesthesia and Critical Care Department at the University College London Hospital since 2019, and currently is pursuing a master's, an MSc in perioperative medicine at UCL. She's a co-author in the Airway Matters massive open online course by UCL. She was on the winning team of the Perioperative Quality Improvement Program poster presentation at the Royal College of Anaesthetists conference this year. And she co-tutors an introduction of perioperative medicine to trainees in the anesthesia department and has special interests in promoting the development of anesthesia and fostering partnerships between Kenya and the United Kingdom. And for today, she will take us through cardiopulmonary exercise testing and prehabilitation. Welcome, Dr. Okello.
Good evening, everyone. Thank you very much for allowing me to present in this esteemed forum. I hope you can see my slides. Can I get feedback? Thank you. All right, I'll just jump right into it. So my topic of discussion today is prehabilitation and cardiopulmonary exercise testing. The idea that I would like to generally convey is more or less to plant a seed within the family of anesthesia in East Africa. Perioperative medicine, as you know, it has been in the limelight for the last 5 to 7 years, and it's slowly emerging. And of course, we've seen it take wings with the African group conducting research in matters perioperative medicine, joining the global movement. The purpose of my discussion is to allow people to, have an idea of what happens in the West in regards to, optimizing patients and especially high-risk patients before they have surgery. And are these techniques and modalities that we can actually apply in the local setup of Africa, particularly East Africa? Feel free to ask questions at the presentation, matters of CPET and prehabilitation, and of course anything to do with perioperative medicine. I would gladly like to answer them. So before I start, I would like to thank one of my colleagues in the department of UCLH, Nicholas Tetlow. He's a specialist in CPEX training and CPEX monitoring in the hospital. He has kindly given me pictorial slides, and I've also received a video from the University College London Hospital CPET archives, just to demonstrate how the whole CPEX testing is undertaken at the hospital. So I'll start with prehabilitation. What is prehabilitation? You'd be surprised that these are things that we probably are familiar with. It's the practice of enhancing a patient's functional capacity before surgery. And the idea is we want to improve their outcomes, and improving outcomes, basically, we think of short stays in hospital, fewer complications, improved pain management, early recovery strategies after surgery. That means a patient is drinking, eating, sleeping, pain is well controlled and mobilizing well before surgery. Right well after surgery. The idea is to improve the patient's length of stay, reduce their postoperative complications, and end up having a happy patient. So why do we do prehabilitation? I'll first start with numbers that are in the UK. As you know, the NHS provides the healthcare service to its citizens, and it's under the care of the taxpayers. So they have 2,404 surgeries per 100,000 population annually, which is quite big. And of course, with the whole pandemic happening, the numbers have greatly increased because there's been a delay of surgeries. It's been shown through the Royal College of Surgeons that the mortality rate is about 4%, with surgical morbidity being a key driver. And the post-operative complication rates range between 15 to 40%, which is quite high. This definitely has an impact on patients because one, they get to stay in hospital or they're readmitted. They also speak of their life just not returning to the same level that it was before the whole procedure. And to the NHS, it's a burden of healthcare because this is money that could have been rerouted to other areas that would probably require attention of patient care and patient services, but now we're catering to patients who need beds in critical care, who need extra dialysis, who need mechanical ventilation, and just occupying the beds that regular people would probably just come, stay for a few number of days and leave. Locally, the ASOS trial did demonstrate that yes, Africans have a low risk profile and have few postoperative complications, but the mortality burden is twice as likely to occur in Africa compared to the global rates. And of course, there was also a study that was done by the Nigerian team that looked at the ASOS trial, but more locally. They did have a reduced rate of mortality. However, their complication rate was just as high. The idea is to perpetuate that surgical complications remain a burden towards healthcare services, and these need to actually be improved in order to have better patient outcomes. So what happens with COVID? As we've seen from COVID and the surgical outcomes from the study that was recently done, most patients who've had COVID, who've had post-COVID syndrome, or who have long COVID end up having post-operative pulmonary complications, and that's associated with a high mortality. This now even makes it more complicated because now we're not only dealing with patients who've got comorbidities, who've got their primary disease that's making them have their surgery, but they are also dealing with the effects of COVID. So we have to establish a pathway that would actually cater for the patient's needs in terms of not only optimizing their physiological reserve, but optimizing themselves as a whole in order to improve their outcomes when they come for their procedure. So what is this prehabilitation? Prehabilitation is a multimodal pathway. So there are different routes and different techniques that are used. It's a multidisciplinary team approach. So you don't have only clinicians dealing with the patients, you have non-clinicians who are also involved. It should be instituted in a timely fashion before surgery because you just want the team to have a good interaction with the patient and make sure that there's adequate optimization before the patient goes through the operating table. And it's a teachable moment for the patient in the sense that the patient gets to learn about their disease, they get to learn how to improve themselves in terms of caring for themselves, how to manage their disease, how to manage their comorbidities. They also give feedback and learn how to cope, because you might find indications that the patient may not be coping well with their disease status. It's more of a psychiatric or psychological problem that's a burden to them. All this allows the patient to be educated, and it's definitely personalized. So there is the initiative to have all patients undergoing surgery to have prehabilitation. However, the plans that are instituted must be catered to the patient's needs. My next slide is basically an illustration of what the multidisciplinary team is. So you have the patient at the core, and you have modalities in such as improving exercise, nutrition, smoking, alcohol, and their psychological health being the major key drivers to facilitate prehabilitation. We do have the clinicians as well, the anesthetists, the surgeons, the perioperative physicians, and you also have surgical nurse specialists. These are nurses who basically take special attention to the patient by the time they actually interact with the surgeon and after the procedure. So for example, where I work at the UCLH, there is a urology center where they do lots of robotic cystectomies. So these are patients who have their bladders as a result of bladder cancer being removed, and then they have a new bladder that's fashioned from their gut. So you have a specialist nurse who actually guides the patient from the time they're seen at pre-assessment, and they tell them about the whole new stoma, how to care for it, how it will look like, and just dealing with the whole new concept of having a new bladder that functions quite differently from other patients. And there's a group focus where a patient comes in and meets people who've had these procedures done before, and they also interact with people who are also meant to have these procedures. Their families are involved, and they get to speak about the whole disease process and how to cope with it. Of course, you have geriatricians as well. Geriatricians come in especially for the elderly. As you know, in the United Kingdom, in Europe as well, the geriatric population is quite big, and so their needs need to be catered for. You have frail patients who come to hospital who need special care from the geriatric team. And of course, you have the occupational therapists who make sure that patients are able to return to some level of good function after the procedure. We can't forget the service managers, the public health staff, and the pre-assessment staff that just make sure that there's smooth sale of services. And when the patient gets back to the community, of course, there's a local doctor ensuring that their needs are met. Whatever instructions that have been done by the hospital team have to be adhered to. And of course, you also have community nursing staff that cater to the patients as well. So what are the components of rehabilitation? We have medical optimization, we have physical exercise, and we have nutritional support and psychological support. In regards to medical optimization, these are things that we have seen as anesthetists, as physicians, as nurse anesthetists and clinical officer anesthetists. Smoking has been established to be a perioperative risk factor that affects up to 25% of surgical patients. We know the effects are very toxic on the lungs, the heart, and the immune system. And basically, it leaves a patient quite weak and unable to meet their surgical demands. The rates of complication include pneumonia, you can have myocardial events, and even failed wound healing. And that will contribute to all this to post-operative complications. In regards to weight reduction, it's interesting because I placed it here because not only is it just part of physical prehabilitation, but you might find that there's some clinicians who actually use medications to have the patient lose weight before they actually have surgery. So I thought I'd just sneak that in, because we all know that weight gain and also patients who are cachexic need nutritional support, because if you're too overweight, then that poses lots of issues when you have your anesthetic, when you have your surgery and your recovery. If you're too underweight, then your recovery and your risk of post-operative complications dramatically increase. In regards to alcohol exacerbates neuroendocrine responses to surgery. And it's been noted that the more alcohol you take, there's a likelihood that you'll experience more perioperative complications. So there are lots of pathways that have been put in place to optimize a reduction of alcohol intake. So the idea is, of course, we would love a scenario where patients stop drinking, but we also have to be realistic enough. So the NHS have instituted pathways to suggest that, yes, a patient can reduce the amount of alcohol that they need to consume before their procedure. And hopefully that can be a lifestyle that they also adopt after the procedure. In regards to management of comorbidities, we have common diseases that affect people, lifestyle diseases. So for example, hypertension and diabetes. Patients need to be optimized in regards to the blood pressure and also ensure that the appropriate medication is instituted. The European Cardiac Society, the American Heart Association are very clear in terms of the kind of medication the patient should be on. So for example, having a patient started on a beta blocker before surgery is unwise. There's a required time that's needed for the patient to actually be on the drug for a while before they actually have their procedure. In terms of the glucose control, there is a new guideline that was done by the Center of Perioperative Outcomes Group that talks about adequate blood glucose control, and the involvement of diabetic nurses, the endocrinologist, to ensure that the patient's blood sugars are well optimized and they have the right medication and treatment before. There are certain drugs that need to be stopped before surgery. So it's very key, because of late we've started to realize that there are certain drugs that actually cause euglycemic ketoacidosis. And patients come in, have their procedure, but they just end up having low pHs and lots of ketones in their urine, and you're trying to figure out what's going on, and they're not in a DKA. But if you look through their history, you find out they've been on some oral hypoglycemic agents that actually cause this during the perioperative period. Anemia, I'll focus on this a bit. Perioperative anemia is very key in terms of its contribution to postoperative complications. Anemia just generally tends to impair your functional capacity, and it increases your risk of perioperative complications. It also makes the patient have the risk of getting a blood transfusion, and they may also have a high risk of mortality. Now, in the NHS, the anemia pathway is pretty clear. Studies have shown that patients who've got low HB levels have a higher risk of having complications and even having a higher risk of death. So certain cutoffs are required. So for example, we have an anemia pathway that exists. So when a patient comes in and they're noted to have a low hemoglobin from their lab results after they have been reviewed by the pre-assessment nurse, this patient is actually referred further for further testing. So they go in to have an iron profile done, and the idea is just to see what their iron profile is, their iron levels, their transport proteins, how their diet is. And once all that's been combined, they get referred to a hematologist, and the hematologist has the responsibility of optimizing this patient's anemia. So for example, they might get IV transfusion of iron, or they might actually be told, go home, improve your diet, have oral iron supplements until you come back for your procedure. This all happens when a patient is seen well ahead of time. So I'm speaking of time periods within 6 to 8 weeks of your surgery. In terms of optimizing your pharmacological therapy, I just wanted to emphasize on perioperative bridging here. You have patients who are on anticoagulants that need to be bridged to a safe dose, or for example, to be switched eventually to enoxaparin or heparin to allow the procedure to happen. So it's very key to involve hematologists here to help you plan how a patient should stop taking their warfarin or their clopidogrel prior to surgery. And this is not just before surgery, but there also has to be a plan after surgery. So for example, if the patient's got a history of atrial fibrillation, this is a patient who's got a history of a PE and is on current treatment, how are we going to transition them from enoxaparin prophylactic dose to treatment dose for them to go back to their apixaban? All these need to be considered before the patient comes for their procedure. The other thing to also consider is active infections that the patient may have. Where I work, there are lots of patients who come with urinary tract infections, and we've had to devise a pathway where we identify patients who are asymptomatic and symptomatic in order to promote antibiotic stewardship, just to avoid the risk of treating asymptomatic urinary tract infections with strong antibiotics and then eventually having patients develop resistance to antibiotics. In regards to nutritional support, poor nutritional status, of course, is associated with very poor outcomes. And it's very important as a clinician and the nursing team who are assessing nutritional risk to see what the nutritional status of the patient is. When you're assessing the risk, it's important to know what they eat, their regularity of feeding, their appetite schedule, what kind of surgery they're coming for, what type of insult are they going to have. So for example, we have patients who have interesting comorbidities in the sense that these are children so adults who come in and they've had ileal conduits done when they were 5, so their plumbing is just literally abnormal, and then they end up coming for reconstructions and refashioning of Mitrofanoffs and things like that, and the surgeon ends up saying, this is a patient who definitely cannot eat after surgery and will have to go on TPN. So it's very important to have multidisciplinary aspects being put in place here, because the dietitian needs to be involved before the surgery, so that at least if the patient needs to be on TPN, they know how they're going to start it and when to start it, and also how to prevent issues like, for example, if the patient's going to eat, we're going to have issues such as refeeding syndrome. So nutritional support is quite important. It's very important to do a nutritional screen for patients. Patients who are underweight can be supported preoperatively for 7 to 10 days before their procedure. It's important to use a screening tool that's locally or globally accepted to just ensure that it's objective. And interventions for normal patients, for example, a regular patient coming for a normal procedure, with enhanced recovery after surgery guidelines that have come up. They talk about preoperative carbohydrate loading, which reduces the insulin resistance and promotes the anabolic state of the patient. It minimizes your loss of protein and your lean body mass, and it reduces the risk of muscle function loss. There's also some evidence to show that giving a patient immunonutrition, such as omega-3 fatty acids, glutamine, arginine, helps reduce hyperinflammation and helps reduce your immune impairment that would actually be caused as a result of surgical stress. If you are to do that, they do advocate for giving a regime at least 5 to 7 days before the procedure. Psychological support is something that's emerging. I've come to learn that mental disorders are quite common in United Kingdom. So you'll find patients who are on mood stabilizers, you'll have patients who are schizophrenic, you have patients who've got depression, you have patients who've had sex changes and are still going through psychological traumas and have PTSD. So all this has to be factored in when you actually are reviewing a patient before they have their procedure. There was a national audit study that was done quite early through the Royal College of Anaesthesia, and it noted that one of the most common effects patients have post-surgery is anxiety. So we tend to always think anxiety is related to the procedure, it's related to the fact that the patient is getting an anesthetic, and it's the whole idea of they're in hospital. But we fail to also consider that it could be related to a new diagnosis of malignancy or a pre-existing social condition that they may have. So it's very important to bring in counselors, psychological liaisons who can actually talk to the patient. Focus groups help, because patients who are gonna have conduits and stomas for the rest of their lives can actually sit down and talk to people who have had similar experiences to kind of get a way of how to cope. Of course, educational interventions do benefit the patient, teaching them how to relax and not be too anxious during the time of surgery. Of course, sometimes it's not allayed, and definitely we don't always want to have a knee-jerk reaction of giving medication. Other modalities can be explored to reduce these adverse mood states. In regards to physical exercise, there are 3 components that I'll talk to, and I'll focus on cardiopulmonary exercise testing a bit. The 6-minute walking test, there's the CPET, and there's just regular exercise. So in regards to the 6-minute walking test, it's something that has been there for ages. It's very simple to administer and very easy to monitor the patient. So it's inexpensive, there's no cost to it. A patient literally just walks along a 30-meter course as many times as possible at their own pace, and then they stop when they're tired or they stop to rest. And you monitor the patient's heart rate, if they're having any dyspnea or fatigue levels at the beginning and at the end of the test, and you just want to know how much of a distance they walked. Of course, it's very important to know that if a patient stopped walking prematurely, you want to know why. Was it as a result of pain? Was it chest pain? Was it difficulty breathing? What, did they just start coughing unexpectedly? And all that has to be investigated. So at least when an anesthetist is reviewing the patient, they can say, okay, with a 6-minute walking test, this is an objective functional capacity that the patient has in regards to exercise stress. In regards to regular exercise, there is no optimal regime that's been defined. There's nothing that is in the books that says that all patients must do something specific. It's tailored according to the patient's needs, and most of the time patients tend to have 1 to 5 day sessions per week, and it's 30 to 60 minutes with actual gym work. You go in, go for your warm-up, have cardio and resistance training, and you have a cooling down session. And the only difference is there is somebody who's actually seeing how tired you are, and they use a box scale. So there are 2 types of box scales. There's the box scale that was the original one that was in 1982, and there's a modified box scale. And the idea is just the clinician or the occupational therapist or the physiotherapist is actually seeing what is the level of exertion the patient has. This is done over a period of time, and of course, when you have a baseline, the team is able to assess how well or how bad you're doing, and of course, it allows the team to know that this is the capability that the patient has reached before surgery. So the expectation in terms of their recovery is anticipated. It's easy to do. They're very simple exercises. They can be done at home. And of course, the other advantage this regular exercising and using the box scale has over a 6-minute walking test is you can actually monitor patients who are on beta blockers using this scale, because with beta blockers, you will not really detect much of a change in their heart rate. In regards to cardiopulmonary exercise testing, so from what I have gathered, it's been in practice, I think, since the early 90s, and studies started coming up in the late 90s to actually explore if CPET testing is valuable. And to be honest, looking at the evidence that exists and even with the actual practice, the main question clinicians tend to ask is, after we've done this test, can we confidently say that if a patient undergoes this test, that their chances of having reduced outcomes are much more than if they didn't have the test? Or, and I think the jury is still out there, but before you make that decision yourself, I'd just like to explore it a bit. It's a whole module in itself, so I just thought I'd bring bits and pieces that are quite valuable. So in the event that you do come across a patient who's had CPETs, or you do come across CPETs testing, you'll at least be able to understand what it's all about. So before I start on how it's done, I will just go to the advantages. So with the CPET monitoring, it's non-invasive, and it's an integrative assessment where it incorporates your muscles, it incorporates your heart, it incorporates your lungs. You definitely need something to make you do exercises. So it's either can be a bike or a treadmill or an arm crank. It's much objective than a subjective Duke Activity Scoring Index, a DASI score, where you give a patient a paper which has lots of questions regarding to mild, moderate, and severe exertion, and the patient decides where they think they fall under. So CPET has the advantage of that it's objective, and it quantifies your physiological reserve, and the health status correlates better with exercise tolerance. So having a CPET allows the team to say, this is how the patient's functional status is. Why do we use it, and what's its indication? So technically right now in London, it's used for risk stratification. So if I have a patient with multiple comorbidities, probably ASA3, for example, if I've put their profile on a risk calculating score, and it's given me a chance of morbidity of maybe more than 1%, and a risk, a mortality risk of 1% or greater than 1%, and a morbidity risk that's probably maybe 10 or 14%. I'd probably want to put them on a CPEX machine just to see what their functional status is. This allows the clinician to have a discussion with the patient and the surgeon regarding resource allocation. Where is this patient going to end up? This patient who has atrial fibrillation, on warfarin, had a myocardial infarction. Let me not even just theorize it. My first case when I came into London was a 98-year-old man who was coming for an implantation of a penile device, and he had had 3 MIs, and he had 2 cabbages, and he was hypertensive, diabetic, and was coming for a very minor procedure. But this is a patient who ended up having to be put in HDU/ICU just because of his CPEX results. And also it helps the team have a discussion about shared decision-making with the patient. So if you have a patient who's quite sick and they don't understand they're quite sick, you can actually have a discussion with them saying, these are your results. Do you remember when you went on the bike? This is how tired you got. This is the chest pain that you had. You could not complete the test because you were extremely fatigued or you were having shortness of breath. And then that will enable them to understand why instead of a regular bed, they'll end up in a critical care bed. It also allows for monitoring of therapeutic interventions. So for example, if you give beta blocker therapy, and if you also want to monitor how severe lung diseases are, you can actually use the machine. And it also shows you what kind of gas exchange abnormalities the patient has based on the plots that are derived from the testing. It's diagnostic. So from the pulmonary aspect, you can actually see if a patient's got exercise-induced bronchospasm, if they have any interstitial lung disease, pulmonary hypertension. There are lots of patients who've never seen a general practitioner or visited a doctor in a while. And when they do their CPEX testing, you find out interesting diseases have come up. You can also be able to detect if there are any ischemic changes, and if a patient has congestive heart failure, any arrhythmias that may have not been noted in the past. And of course, if the lungs are working and the heart's working, what else is not working? Is it the muscle? So you can actually suspect any muscle myopathy or any mitochondrial myopathy that may be manifesting. It's also been used in sport areas, those who are quite rich and have accessible facilities to use CPEX machines. Athletes use them. And for prehab, we believe it's feasible. It can be used in optimizing a patient's functional capacity and monitoring them as they do that. And it's a way of prescribing exercise. So for example, a team can decide this patient needs the procedure, their functional capacity needs to be improved. So yes, I will sort out how they eat. I'll make sure they're in a good place in terms of their peace of mind. I'll make sure that their medications are well optimized, but I'll also make sure that they are able to sustain some good exercise before they have their procedure. So the device looks like that. Basically, you have a barometric pressure device, which measures your external and your internal pressures. There's a gas analyzer that looks at your carbon dioxide and your oxygen levels, and it looks at your expired gases, and it looks at the amount of oxygen that you're taking in. You have a flow meter, which has a 3-liter calibrated volume syringe that moves at varying speeds, and that is able to at least see how much gases and oxygen you're inspiring and expiring while you're doing your exercise. And then there's a whole integrated function that looks at the flow of your gases and the concentration of your gases, and all this is put into a computer and it's analyzed, and you get a 9-panel plot. Before we do any CPEX testing, it's always important to see if there are any contraindications that the patient cannot have the testing done. So according to the American Thoracic Society, there are absolute contraindications. So if you have a patient who's had an MI 3 to 5 days before the CPEX, unstable angina, uncontrollable arrhythmia causing symptoms such as blood pressure compromise, syncope attacks, acute active endocarditis, any acute myocarditis or pericarditis, if they have a symptomatic severe aortic stenosis, they're in heart failure, which is poorly controlled, you have a suspecting or a leaking aortic aneurysm, uncontrollable asthma, not on medication, and they're desaturating on room air less than 85%. Relative contraindications include untreated left main stem coronary stenosis, asymptomatic severe AS, severe untreated blood pressure. So if you have systolics greater than 200, diastolics greater than 120, tachyarrhythmias, bradyarrhythmias, hypertrophic cardiomyopathy, pulmonary hypertension, thrombosis of the lower extremities until treated. And if they've had a PE within 2 weeks of the procedure, a large abdominal aortic aneurysm, if they have an advanced complicated pregnancy or any electrolyte abnormalities, because these definitely will just affect the whole testing. So when a patient comes in, they've been referred by the anesthetist or the perioperative physician. There's a checklist that they have to fill, basically looking at their history and ruling out any contraindications. The technician tends to explain the procedure to the patient after they've already been informed by the primary team, and just to eliminate any sense of anxiety. Usually patients are advised to come with just regular spotting material, light clothing, something light so that they don't get fatigued. They also have a HB check that's done to verify what the HB levels are. It's very important to know because the HB does affect the CPEX values. So if you're dealing with a patient who's got an anemia of 11 and 10, then it has to be clearly indicated because the technician has to know, because that means that if they had a normal HB, their values would be different. Basic spirometry is done to assess the pattern of breathing. We calculate the regular FEV1, FVC ratio and calculate their maximum voluntary ventilation. We attach the patient to an ECG monitor. It checks the rhythm just to rule out any form of abnormalities. And of course, we go over their cardiac medication. What have they been on? What have they been on? If they're on beta blockers, when was the last time they took it? Any stimulating medication? Did they have coffee? Did they have an energy drink? It's very important to know. And then you finally attach a face mask. And of course, you have to explain because many patients tend to be claustrophobic. So just a quick recap, it's just of the physiology. Basically, you have a patient breathing in oxygen and removing carbon dioxide, oxygen being delivered through the heart and going to the muscle tissue where it's consumed, and of course, carbon dioxide being released and being delivered back into the lungs for it to be exhaled. That's the physiology in regards to CPET. So just a few things to consider. If you have a patient breathing in room air and they take in about 21% of oxygen and they breathe out about 15%, it means the oxygen uptake is 6%. And if our normal minute ventilation is 5,000 mils per minute, it means our oxygen uptake, which is our VO2, ends up being 300 mils per minute. And the same principle applies with your carbon dioxide levels, and that gives us a VCO2 of about 250. I just posted this slide to just remind people about the respiratory exchange ratio, looking at the ratio of carbon dioxide removal to oxygen uptake, which lets us know how the cellular demands are and how to derive our ratio of 0.8, and just the normal general principles regarding aerobic metabolism. So in regards to the test, patient rests for 3 minutes on a stationary period, and all they do is just breathe. And while they're breathing, the machine is taking their breathing patterns and it's being recorded. Then you have the unloaded cycling, which takes another 3 minutes, where the patient cycles against no resistance. There's no resistance, they're able to do it quite comfortably. It allows them to get used to the machine, and it allows the technician to get baseline measurements while they are cycling. Then the main test is the ramp test, which lasts about 10 minutes, and it's continuous exercises, and they're not meant to stop. They're meant to go as far as they can or as much as they can. And what happens here is now the technician starts to increase their resistance by 5. So initially starts at 0, goes to 5, goes to 10, goes to 15, and goes to 20. So it's meant to last 10 minutes. Most of the time, geriatric patients don't last 10 minutes because they actually say, I'm tired, I'm quite fatigued. But patients who are able to manage, those who say they walk or they're able to do regular exercise, actually complete the test. Then you have a recovery phase where there's literally no resistance, or you can have low resistance for 3 to 5 minutes. Then you stop cycling, and the data, of course, is collected until the patient is off the bike. So I have a video here just to show you how it's set up. This is one of my teachers. I don't know if you'll be able to.
pulse revolutions per minute. Soon, resistance will build on the bicycle at a preset rate, so the patient is cycling therefore making the patient work. The test aims the patient to cycle up the hill for about 10 minutes. Once the patient can no longer cycle, resistance is removed. The patient will keep cycling very slowly to cool down. The patient will then stop cycling, but stay seated on the bicycle for a couple more minutes.
Okay, perfect.
The patient sits on the cycler.
There we go. So what are the indications to stop the test? If a patient has angina, if they have any ST changes, the patient has to get off the machine. There are moments we've seen patients get arrhythmias, they get quite breathless to the point that they can't breathe. Their blood pressure tends to shoot up or drop significantly, requiring attention. That is why when I showed the first slide of the CPEX machine, you do have the machine, but right next to the machine is the resuscitation trolley. Patients have had severe desaturation events, and you also have loss of coordination, mental confusion as a result of the arrhythmias, and dizziness and fainting as well. So once we gather all the data, what people end up seeing is a 9-panel plot. Now this takes lots of work to interpret, but I'm going to focus on a few that are quite important. So these are the things we look out for when we get the CPEX results from the technician. So you have 9 plots, and basically it's looking at ventilatory equivalence and your VO2 and your VCO2 against time, and also looks at your heart rate and how you're responding. And much as you have the 9-panel plot, they also give you the 12-lead ECG. So at least you can know what the patient's monitoring or what their heart monitoring is like. So I'll move to the third plot, which is panel 3. And this is basically what I have explained. And the reason why we focus on panel 3 is it allows us to calculate the VO2. And you have your resting phase where the patient's doing nothing. And you can see you have basically your VO2 that's plotted against time on the left, and on the right you have your VCO2, and WR is literally your work ramp. So that's when you do the exercise, and it's marked in green. So you have a patient here at rest, and then this is when they start to cycle, and it's to get their baseline measurements. And as you can see, as we're moving towards the exercise zone, you can see that their VO2 and their VCO2 is slowly starting to creep up. Then once they start their exercise, you can see the VO2 uptake is actually increasing, and it reaches a point in time where the VCO2 overtakes your VO2, and now your carbon dioxide production is much more than your oxygen being consumed. And then once we stop the exercise, the numbers start to drop. So these are quite important. So in order to calculate the VO2 of this patient, you can actually look at it manually and correspond to where the highest peak of the VO2 is. And when you do that, it's about 3.5. And of course, you'll calculate it with an 80 kg patient, which gives about 44 mils per kg per minute. But the machines actually give you these calculations. So you have the 9-panel plot, and you'll also have an algorithm and a report that's been done by the machine to just give you the values so that you can correspond to your manual checking. So the main take-home message here is the higher the VO2, the fitter the patient, and that's what we would like to see. So there's this green line, which basically shows a rate or a stage of inflection. You have an exchange of where your VO2 and your VCO2 exchange roles in terms of how they increase. And this is demonstrated in panel 5. And basically you have a slow rise, and then at some point there is a change in the VO2 and your VCO2 production. So this is what we're seeing here in panel 5. So you have your VCO2 right here, and of course you have your heart rate, which is in red. So as your VCO2 production is increasing, at some point it's no longer linear and it changes, and that basically tells us the point where the anaerobic threshold begins. So the inflection point is where CO2 produced exceeds the rate of O2 consumed, And it's very important to note what value that is. And of course, the machine will give it to you. So when you're interpreting it on the machine, you want to look at the level where that change is and also see the corresponding level of your VO2. So I want to know where my VO2 at the anaerobic threshold, where my VO2 numbers are. So I will look to panel 5 that has my VCO2 and my VO2 plotted against my heart rate. And the point where there was the inflection, I will look at where my VO2 number is, which is about, I think, 1.6. And then I will also know, it's also good to know what the level is here for my VCO2, which I believe is probably 1.5. So like I said, if you want to know what your VO2 at the anaerobic threshold is, you'll calculate it as, this would be 1.6, and you multiply it against an 80 kg patient, which turns out to be 20 moles per kg. So the higher the number, the happier I am. The next thing to look at is, what are my ventilatory equivalents? Do I need to know this? Yes, because it allows me to understand what my VQ mismatch is. Am I dealing with lots of lung dead space? And the idea is equivalence should decrease with exercise. So you're looking at the ratio of your minute ventilation to either the carbon dioxide produced or your oxygen consumed. So the key question you need to ask yourself is to eliminate 1 liter of carbon dioxide or to take up 1 liter of oxygen. So when you go to the panel, you look at panel 6, and basically it looks at your ventilator equivalents of oxygen, and there's also one against carbon dioxide, and it's against time. And you want to look at the level where the anaerobic threshold line is, which is the green line here. And you should be able to calculate the values which correspond to about 20 and 22. So the lower the ventilatory equivalent is at the anaerobic threshold point, the better it is for the patient. The higher it is, the unhappier that I am. It basically means that the patient might not respond well to surgical stress. So always remember, it's panel 3, it's panel 5, and it's panel 6. So I want to know what my VO2 max is. I want to know what my VO2 peak is at the anaerobic threshold, and I want to know what my ventilatory equivalents are. Why is all this important? Basically, we know surgery causes inflammatory response systems, and lots of studies have shown that as a result of surgery, there's an increased demand of oxygen at the cellular level, and patients who basically have poor reserve and the inability to actually have oxygen delivered to the cellular level have very poor complications post-operatively. So the AHA actually recommends functional capacity assessment as a pre-assessment evaluation. And a study done in 2009 actually demonstrated a reduction in mortality in patients who had better cardiorespiratory function. So I'm just gonna go through the evidence just to see what supports the use of CPET testing in perioperative medicine. In as early as 1999, a group actually looked at patients who had heart failure and ischemia, and they actually underwent CPET testing, and they took about 187 patients, and they noted that if you had an anaerobic threshold that was less than 11, you had a higher mortality, and if you had preoperative ischemia, your mortality even was much higher. So like I said, you want an anaerobic threshold that's greater than 11. They also went to see if it could be valuable in using it as a screening test for patients who underwent major surgery in the geriatric population. And they looked at patients who are above 60 and below 60 with known cardiac disease. And they noted that if your anaerobic threshold was less than 11 and you had major surgery, your CVS mortality was 4.6. A higher rate of admission into ICU. If you had anaerobic threshold more than 11, which is great, but you did have a cardiac comorbidity or your ventilatory equivalent was quite poor, you ended up being in HDU and your cardiovascular mortality was 1.7%. However, if you had AT level above 11, ventilatory equivalent less than 35, you ended up being in the ward, and of course they reported a mortality of 0%. So having a positive CPET test showed that you had a reduced chance of mortality. There was also a study that was looking at the 90-day survival rate of patients who actually had impaired functional capacity. And if you look at this Kaplan-Meier curve, you basically have patients who had ventilator equivalents greater than 34 having a less chance or a less likelihood of survival. And basically, these guys looked at patients above 55 undergoing major surgery, and they were looking at their anaerobic thresholds and they're looking at their ventilator equivalents. And they actually thought anaerobic thresholds less than 10.9 was 6.8 times likely to die. Patients who had AT levels less than 10.9 was 6.8 times likely to die in hospital within 90 days. And if you had ventilator equivalents greater than 34, you had 4.6 times likelihood chance of dying in hospital. So these are one of the studies that actually were pushing people to use CPECs in assessing their patients. And then they asked what of patients who had submaximal results, did they have that affect their outcomes? And this study basically demonstrated that with poor numbers, if you had anaerobic thresholds less than 10, your post-operative complication rate was much higher, which was shown in this study. So they're basically looking at patients who had major elective surgery, looking at their rates of complications within the different systems or organ systems in their body, and were correlating and seeing the relationship that if they had a very good anaerobic threshold, what was their chance of getting a post-operative complication, which basically indicates that your functional capacity kind of gives the clinician an idea of what or how you can actually respond to your surgical stress. This was also a study that was done in 2016 that was looking at patients who underwent AAA repair and looking at their risk of mortality. And just looking at these two values here, it just showed if you had an anaerobic threshold less than 10, then your 30-day mortality was actually quite significant. And same thing applied to having a peak VO2 that was less than 15. So at the end of it all, there was a huge review that basically looked at all these patients, and what they ended up saying is your 90 to 3-year survival was about 9 to 11 mils per kg per minute. That's the threshold they had for the anaerobic threshold that they had in mind. So if it was less than 9.9, things are not looking great for you. Things are better for you if you have numbers of your VO2 being above 15. And of course, your mortality went up and your morbidity went up if you had your anaerobic thresholds less than 10. So be that as it may, when you have a 9-panel plot presented to you, the question to always ask is, has a patient managed to complete the test? What's my VO2 peak level in panel 3? What's the relationship of my VO2 to my work? Because that also enables me to know if there are any lung abnormalities that the patient has. Can I determine my anaerobic threshold? Can I determine my VO2 at the anaerobic threshold? What's my heart rate response? What's the ECG reading? Does my oxygen pulse increase with exercise? If not, why? And is there any ventilatory limitation for the patient? So take-home messages are peak VO2, you want something above 15. Your VO2 anaerobic threshold, the higher it is, the better for the patient. Your anaerobic threshold, we want numbers that are less than 10, and we want numbers that are greater than 10, and we want ventilator equivalents that are less than 35. There is also inspiratory muscle training, which is an emerging technique that's been there before, but it's not been used in prehab. And the idea is using a handheld device to facilitate resistance training for your respiratory muscles. And this is guided by your maximal inspiratory pressures that are generated when the patient actually breathes through the device. There are very few studies that have actually shown if it's beneficial. So it's something that's currently being explored at the moment. Then the other question to ask is, if I don't have a treadmill, if I don't have a bike, can I use something else? There is the arm crank ergometry. which is basically just cycling with your arms. And the AAGBI actually did a study to look at the value of arm crank testing and to see if the numbers were quite different from regular CPET testing with a patient. And basically they noted that the anaerobic thresholds and your peak VO2 values were just less than 30% compared to your standard CPET test results. And they attributed this to the fact that patients may have smaller or less conditioned muscles, which may limit exercises when the heart and lungs are not stressed. But they did demonstrate that using arm ergometry measurements can actually allow a patient to be risk stratified and placed in the right resources in terms of post-operative care in order for them to actually receive the care that they deserve after the procedure. And it's something worth considering, especially if you're in units where they're not, in terms of accessibility to a treadmill or even a cycle is impossible. Before I ask about any questions, I think it's quite important to say that it's very possible to create a pathway of which you can devise modalities that can improve your patient's outcomes. Nutrition is something we've encountered before, so is optimizing a patient's care. We need to highlight the key features within Kenya, within East Africa, that bother patients. Do we have a problem of hypertension? Do we have a problem of diabetes? Do we have a problem of anemia? Should we develop pathways that can be used to actually optimize these patients before they have surgery? Can the surgeons be involved? So if a patient is coming for surgery and the surgeon is aware that this is a patient who has anemia, what can they do as the patient is being prepared to have their procedure done? It's also important to ask, is it worth investing in a machine in order to do these results? CPEX sounds lovely, it sounds great, but it takes training. It's a 5-year, it's an MSc, it's a 5-year training job. The machines are quite expensive to buy, but they last for a long period of time and they can be used for a different number of patients. Of course, you also have to factor in regular regular maintenance, such as ensuring calibration is done, the proper equipment, ECG monitors, paperwork is there. And it has to be a sustainable service in the sense that if I'm going to use a CPEX to assess functional capacity in my patients, then I have to make sure that the numbers actually allow for this service to seem quite useful, because admin will always ask, yes, it sounds good, it may help us decide who can end up in an ICU bed or in a HDU bed, but at the end of it all, is it sustainable? We are in a different society in Kenya. The healthcare cost is to the patient. So much as I have focused on CPEX, it's also important to know that even simple 6-minute walking tests are quite important for the patient. If that's something that still cannot be done, just even having a subjective DASI score or a DASI index can be used to assess functional capacity, and using your risk scores to allow for patient planning during the perioperative period. Thank you. Angela, back to you.
Hi, Maxine. Sorry, I apologize. I'm having some network issues. What a wonderful, wonderful presentation. It was, it's very eye-opening, tells us a lot about gold standard and what's there, what our options are, what to think about. The physiology you've gone through gives a snapshot of what's the baseline. This is us having heart and lungs at the core of our business as anesthetists and anesthesia providers. I wanted to ask, sorry, but this everything is hanging on here. I wanted to ask, at UC, in your practice at UCL, for prehabilitation, who's sort of how is this led, sort of, it's multidisciplinary.
Yes.
So this patient, BMI of 40 coming in for a lap chole, and there's this plan, there's this prehab plan. Just if you could walk us through that as I try and change devices, sorry.
Okay, so one thing to note is that in the NHS, most trusts are specialized if that's safe to say. So for example, my trust primarily deals with thoracics, oncology, urology. Yes, there's orthopedics in other cases, but the main things that they are popular for. So for example, if I would isolate robotic cystectomies, the perioperative pathway is a primary initiative from the perioperative physician. So that's basically an anesthetist. It's an anesthetist who's done periop medicine. And of course, they have had to come together with the anesthesia team to come up with pathways of which the surgical team are very comfortable following and working with the nursing team as well, because the surgeons most of the time have the primary task of just discussing the procedure with the patient. But when it comes to pre-assessment, it comes to planning the procedure, the surgeon has a specialized team. So there's a pathway coordinator who sorts out the day of surgery when the patient, when the patient needs to be seen by other specialists and stuff. And of course, there is the specialist nurses who now deal with the whole process. So for example, Mr. X is coming for a robotic cystectomy and his procedure is going to be in August. So what will happen is the urology pathway coordinator will book his surgery, and then she will send him to the pre-assessment clinic. At the pre-assessment clinic, before COVID, the pre-assessment nurse would see the patient physically and screen the patient, would ask patients specific questions, take the vitals, do a physical exam. And if they noted this was a high-risk patient, then they had to be referred to the anesthetist stroke perioperative physician. So the perioperative physician, then with the anesthetist, or either or and, decide a plan for the patient. So they'll say that if you are coming for a robotic cystectomy, you have to have a specific test done. So what we plan for these patients, they need the regular lab tests, and then they undergo the iron profile. They have to be seen by the hematologist. They go for their CPET testing, and before they have their procedure, they usually go for an examination under anesthesia, and that's also planned as well. And then once all that is done, if the patient needs more optimization, then the perioperative physician, together with the lead of the pre-assessment nursing team, have to now liaise with the nutritionists and the psychologists to optimize the patient before the procedure. In regards to matters surgical, dealing with stomas and how to care for stomas, patient education, and family support, the urology specialist nurses actually deal with that. And they actually take the patient through the process of what it means to have the ileoconduit, what it means to have this procedure after surgery. And then they are encouraged, or they delineate any rumors or any fears that the patient has. Once all that is done, the anesthetist gets back the information and then has a discussion about anesthesia to the patient. And this is where now all this is put together, and the anesthetist stroke perioperative physician makes a checklist and says the teams have been involved and the optimization has been done. The patient is in a good place psychologically. Now I can talk about matters anesthetic. Much as this is happening in the actively, there is also talk in the background. So there are common multidisciplinary team meetings that are held by the surgeons, the nurses, the anesthetist, and the perioperative physician. And that's basically what they do, is they come together once a month and they look at all the patients scheduled for surgery, maybe for the month of August. And then they'll say, this is a patient who needs this help. This is what they need to do. They need to see a cardiologist here. And then they plan their timings of surgery. So by the time a patient is coming for their procedure, they've literally gone through their CPET testing. They've had their investigations done. If they had an anemia, they got their IV iron. If they were on anticoagulation, their bridging therapy has been done. So by the time they come to us in the post-anesthesia care unit, we are more or less just continuing the pathway that's been set for them. Back to you.
Thanks, Maxine. Thank you. Nice. Let me get into the chat. Let's go up. Let's see. A lot of accolade coming in for a wonderful presentation. Kevin Umani asks, is the revised cardiac index score reliable for cardiac patients for non-cardiac surgery?
Yes. It's one of the screening tools that we push to use, because sometimes, you know, you have patients who've got, yes, they're yes, they are not cardiac, but they do have these risks that present to them. So if I have a patient who's chronic kidney disease, they have diabetes, they have pathologies that clearly would just promote issues post-op, I would definitely use it. Is it commonly used? No, in the sense that now we push for the SOT scores, which I remember discussing in a previous CME that we had. We have POSSUM scores as well. I think now even the American College of Surgeons have even a better scoring system, because all you need to do is go to their EndScript data and put in the patient's procedure and their age and their comorbidities, and they literally give you exact, or not really exact, but accurate predictive values regarding the possibility of the complications. So they'll tell you there's a chance that you have ileus, there's a chance that you'll have pneumonia, there's a chance that you will not open your, you want to pass, open or pass wind. It's very important to kind of figure what risk assessment tool would be suitable for your patient. There's so many that are coming out now, and the idea is to see how valid they are. And if it's one thing to talk about validity in terms of research, but at the end of the day, I always say, put it in your clinical picture. If you use it for your patient, and it allows you to assess a risk, and you can have a discussion with your patient and plan for your patient's post-operative care. At the end of it all, when your patient goes home, were the complications less? Did they stay in hospital for a lesser period of time? Did you use your antibiotics judiciously? Was pain control well managed? Did you have your ERAS in place? And it doesn't end there. Perioperative medicine doesn't end when the patient is discharged. There's always that risk of readmission within 30 days, within 90 days of surgery. And now they've gone even a step further to see what their year survival rate is like. So it's a continuous follow-up. So I would suggest using a tool that would suit you, would be more, would give you the desired results that you'd expect. And then you can actually say, I've managed 15 patients and I've used the Lee revised cardiac risk index score, and these are the outcomes that I've had.
Absolutely. I think you're right. I think maybe like any test, any tool will have its highs and lows on different areas. There's no holy grail for everything, obviously. So the risk, the cardiac risk tool, then as well, it will have low discrimination for example, vascular surgery, if that's what, I'm not sure what Kevin is asking about. So it's good at picking up the big cardiac event and maybe the lower risk patients, but absolutely. And I think you're right. You have to take your patient in a context and apply the appropriate tool for your stratification. Yeah. Maxine, I won't go, let me veer us back to this presentation. How do you take care of confounders, such as high carbohydrate meals that may be consumed before the CPEX, given that carbs generally give a higher VCO2? Any dietary instructions before CPEX? Thanks.
Yes, patients must sorry, I should have said that. Patients must starve. So patients actually come so the CPEX testing is, so you more or less tell a patient to not eat at least like usual fasting guidelines for anesthetics. So CPEX tests are mostly done at 8 in the morning. And they're not done in massive numbers because it takes a while. And of course, you have to deal with a nice, gentle Mrs. Susan Brown, who's in her 90s and needs time to get on the machine. So you might find that, yes, it's a 10-minute procedure, but the whole thing takes about 1 hour. So patients must starve before they come. They must come with light feeding. And of course, there's monitoring before and during the procedure and definitely after. So yes, there is dietary instructions. They must starve. Yes.
Okay, thanks.
They're allowed to have water.
They're allowed to have water. I don't know, Maxine, my anaerobic threshold, wow, it would be right down there at the resting phase anyhow. So this is facilitating, and this is someone's comment, Falana Ebenezer. This is facilitating, and this help in cardiopulmonary testing and categorizing into high risk or non-risk, low risk patients, I suppose. And his comment is that we need to appeal to our governments to help equip our hospitals, and asking, is CPET different from a Goldman risk of assessment? Which the answer would be yes, yeah?
Yes, it is. Because, yes, it is. It is. It's more objective. It's more active. You're not only just looking at the heart and the cardiology aspect of it, or you're looking at the lungs, you're looking at the mitochondrial level, and it's very important. One thing I also need to highlight is, now that we have lots of COVID patients, post-COVID, and these probably, we have had patients who've been in hospital for 3 to 4 months, and then they go home and they need procedures done. So they either have long COVID or they have post-COVID syndrome. Discussions have usually been quite sketchy regarding how to proceed with them, because of course the anesthetist doesn't want anything to do with the lung. This is a patient who post-COVID has bad lungs, probably has had multiple PEs. Their functional capacity is definitely reduced. So there's been current discussion and looking at the value of CPEX in assessing the functional capacity of these patients. And of course, right now it's in its preliminary stages, and lots of hospitals are trying to, do studies locally just to see how patients respond to it. But the most important thing is, of course, there's been talk of the absolute and relative contraindications, but in such cases, when a patient needs surgery, considering that there's been a huge rise of disease progression with cancer as a result of COVID. And now you have a patient who needs to have their surgical procedure done. I mean, it's cancer, it has to go, it has to be removed. So the question needs to be asked that, if I put a patient through a CPEX machine, will I be able to assess them functionally in a way that I can actually plan for their care post-op? And there's a lot of chatter that's actually trying to push for this, because they feel like this might be the only possible way. Yes, you might do a scan, you might do an MRI, you might know what the lungs look like in terms of imaging, but what's the actual stress that the patient might actually have? Most closest thing you can imitate of surgical stress is exercise. Yeah.
So Maxine, let me ask, so like for example, at UCL, would CPEC in an appropriate patient sort of be standard of care, or are there patients who'd go through it? This is a self-answering question, but would go through, and the approach being that we'll take it, we'll see it as he goes. So we are post-op, let's admit to a high care, an ICU, and see how you're doing and step down. Or do you have any studies locally on your end that show for the practice there that there's a, what do you call it? Would you say a clinically significant change? I know that data is tricky, obviously. Length of stay in ICU of 8 hours versus 6 hours, you can usually bring it to heated discussions. But what's your even anecdotal experience? Maybe
so I'll first say that CPEX is not for all patients. CPEX is indicated for high-risk surgical patients. The first starting point is maybe a patient who's going through a major complex procedure. And then if it's a quite complicated patient in terms of their physiological function. And then the other thing to consider is what are your anticipated complications? It's very important to try and figure out the worst case scenario. And of course, your CPEX results would help you kind of get to that point. But the reality of the matter is, does it improve outcomes? No, it doesn't. My boss feels that yes, it's good to do CPEX, but he's like, it won't help, really. It won't. It'll help me know what the patient is gonna go through when they're in the HDU, ICU, but will it reduce their length of stay? No. Will it reduce because at the end of it, if they get an AF, they get an AF. If they get a peri-op MI, they get a peri-op MI. Did CPEX result reduce that? No, it didn't. I think it's more indicative for the clinician to plan their treatment rather than it being beneficial for the patient. And that's why the controversies regarding CPEX is out there. they push for it, they believe it works, and they say you should do it. But at the end of the day, no one will come out and stand and say, oh, it actually improves surgical outcomes. I have this number of patients who've gone through CPET machine and we've ensured that their mortality rate was down. It's hard to tell. Patient doesn't follow a textbook.
I think your answer is perfect. Like what the value of it is in, and that you've made it so clear. I was preempting a question that's come in because we talked about sort of your exercise tolerance. So how do you handle bedridden patients, such as critically ill patients planned for surgery? I'm guessing they're asking, how do you, Maxine, handle it?
How do we handle bedridden patients?
Yeah, how should one, in this context of...
So most of the time they wouldn't go through CPET testing.
Of course.
Most of the time we tend to look at their history, and there's usually like a meeting where people look at their any past surgical or anesthetic events and look at their post-operative stay. Most of the time, bedridden patients require input from their primary team. So you notice that physicians come in. If it's a neurological patient, the neurology team is on board because they're able to tell you that this is where the patient started, this is where they are. The idea is to minimize your complications. So it's very important to have a candid discussion with the patient, saying that there's lots of risk that you are exposed to if you have surgery in an anesthetic, in terms of your recovery, risk of pressure sores, risk of prolonged ventilation, for example, issues regarding nutrition. All that needs to be considered. So what usually happens is, so for example, in my institution, the perioperative physician who's on duty tends to have a discussion with the anesthetist on duty on that day of surgery, and they basically discuss the high-risk surgical patients. And when the physician has time, they usually take a cruise through the theater and just peep in to see how the patient is doing most of the time. And they kind of get this feedback of, this is how the anesthetic course has been, this is how the surgery has been like. So most of the time he'll say, looking at what you've gone through, I would suggest you bring the patient mechanically ventilated. Yes. So for example, we had a patient who has had ileal surgery since 5 years of age. So his plumbing was off the whack. No one knew what was where, and he needed refashioning. Came in, had his procedure, 2 days later developed ileus and ended up having a leak, an anastomotic leak, which was confirmed by a CT scan. This patient had never stepped out of bed. It's not the same as being bedridden, but he was 4 days post-op, but had not been out of bed, and ended up having to go for surgery. And when the anesthetist took over the case, because there was a changeover, he thought he would actually extubate the patient, but the POM physician walked in and said, no, I'd rather have this patient intubated. Let them come to the unit. We'll leave them sedated overnight, and then see how to manage everything. And it turns out the patient had massive abdominal distension. We were struggling with mechanically ventilating the patient. We ended up extubating the patient after 3 days, and not even just overnight sedation. So I think it's very important to strategize with the team you have. I can't emphasize as much as I can the concept of multidisciplinary approach. We have to work together as a team. So if you're in critical care, you have to have a discussion with the anesthetist and the surgeon, because at the end of it all, it's not who's right or what's the best plan, but what works out for the patient.
Yeah, absolutely. Wow. Absolutely, I agree with you completely, and especially these critically ill patients. It sounds like this is like the science behind the optimize as we can get, if we can get it, that team, and whether to extubate post-op. Some of that is gut feeling. The numbers look good, but there's something nudging you. So this for me is a great a nudge in the direction that there's a science behind this. And So,
and I think the Americans have gone a step further. I think in Duke University, they're now doing studies. They're looking at muscle studies in critical ill patients and just seeing what their progress is in terms of patients who are prolonged under mechanical ventilation. What's their cardiac index? What's their oxygen requirements and their oxygen demand? How does their body respond in general? So they look at their caloric intakes, their muscle sizing, and if there's any difference. And some have even come to realize that much as we think people use glucose during this recovery time, they actually use more fats, really.
Oh, fats,
metabolism. So I think it's more of, there's lots of studies that are emerging to see of techniques that one can use to see the assessment of recovery or the recovery profile for bedridden patients or patients who are mechanically ventilated. But as I said before, there's always that need of pre-planning and always stopping in between care and just catching up to see where things are.
Yes. Oh, Maxine, I feel like I've been on a couch with you. It's 7:24 on the clock I'm using. I can't believe we'll use up all our time.
Great.
Thank you so much, Ido. Thank you so much. I'm certain our audience feels that they feel a bit more equipped to navigate the perioperative space. I'm receiving wonderful feedback, even on private chat about your presentation and the ensuing discussions. And as always, you're always available for further discussions. Your contacts are available in our secretariat. And we thank you for your time, Maxine. Honestly, thank you for a wonderful presentation.
Thank you.
Thank you. So for KSA members and our broader KSA family, thank you for tuning in. It really is for you that we congregate. The KSA Executive Committee, we thank you for organizing and running the CME calendar for us. For Shelmith, our faithful KSA administrator, thank you for all the time and effort you put into hosting one successful webinar after another. Please, all of you, visit our website, anaesthesiakenya.co.ke. We upload all our presentations. Subscribe to our YouTube channel. Follow us on Facebook. I'm not sure about TikTok and the rest, but we invite you to share your preferences, your suggestions as regards the subject matter that we tackle during these discussions, because your questions, your comments, your contributions and criticisms are exactly what make for a rich and rewarding interaction. CPD points and certificates for nurses, CEOs, and non-Kenyans, those will be sent by email. And remember, we are counting down to our 28th KSA and 8th CCSK annual virtual scientific conference. That's a mouthful. 18th to 20th August. If you visit our website, you can register for that. A quick one, our sister society, CCSK, Critical Care Society of Kenya, they're hosting their first virtual half-day symposium with the theme sepsis from lab to bedside. That's 17th July. Again, if you talk to our secretary, go on our website, you'll find the information. And because I'm running at a clock, please accept our standing invitation to our webinar series. Tune in next week, Thursday, July 8th, same time, same place. Thank you, Maxine, and good night, family.
Thank you, everyone. Have a good evening.